Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, the role of inferior petrosal sinus sampling in the era of modern neuroimaging, is presented by Dr. Andre Beer-Furlan. Now please hold as there will be a brief delay while we change presenters.
Can you listen? Can you hear me?
Yep, we can hear you.
Okay. And do you also see my full screen presentation?
Yes.
Okay, very good. First of all, thank you for the opportunity. Thank you for the Pituitary Network Association. You guys do great work educating patients with pituitary tumors. And so I'm very happy to be here. And today we're going to talk about the role of the inferior petrosal sinus sampling in the era of modern neuroimaging. So my name is Andre Beer-Furlan. I'm a neurosurgeon at Moffitt Cancer Center, and I specialize in skull-base and pituitary surgery as well as neuroendovascular surgery. So I think my unique training gives me a very unique view of these patients. Often pituitary surgeons do not perform IPSS or inferior petrosal sinus sampling. And I'm very fortunate to be able to see these patients from our multidisciplinary interaction with endocrinology, other way to diagnosis as well as surgical treatment of their tumors. So have no disclosures. And the goal of this talk today is to highlight the rationale for inferior petrosal sinus sampling, discuss the current and future of neuroimaging for Cushing's disease diagnosis, and describe the techniques, indications of IPSS, and most importantly, when not to do it. A little bit of a background. This is probably easier for endocrinologists. For neurosurgeons, it is not as straightforward. Neurosurgeons that are not used to treating Cushing's disease patients may not know all the details and process in prioritizing diagnosis of Cushing's disease. But it's very important to establish the priorities first to diagnose hypercortisolemia, then subsequently trying to differentiate whether that's an ACTH dependent versus independent hypercortisolemia. And then the third part is in this sequence is differentiate these patients with the Cushing syndrome from Cushing's disease, which is production of the ACTH coming from the pituitary gland from ectopic states of ACTH secretion, meaning the ACTH being secreted by other tumors in other parts of the body. This initial screening or establishing of hypercortisolemia and the diagnosis of Cushing syndrome is established when at least two different first-line tests are abnormal. And physiological hypercortisolism has been excluded. Once that diagnosis is established, then additional evaluation is done to identify the causes of the hypercortisolism. I honestly think this is one of the most challenging aspects of managing Cushing's patients, because it is not as straightforward. Obviously, patients that have a full clinical picture and full laboratorial evidence, those are the textbook and easy to diagnose, but in clinical practice, this is not what happens. And a lot of patients, they may have mild symptoms, equivocal laboratory investigation with some abnormal labs and other normal labs. And often this process in diagnosing or establishing hypercortisolemia may take months to years in patients with mild disease. Most importantly, it is very common, and there's a lot of overlap of the physiological Cushing or pseudo-Cushing states. Those are patients with physiological forms of hypercortisolism, and a lot of the clinical features and signs and symptoms are the same as the patients with a pituitary or a source of independent source of production of ACTH. One thing I'd like to highlight is that we don't see very common in pseudo-Cushing states patients developing cutaneous symptoms, so easy bruising, thinning of their skin, friability, and wasting and muscle atrophy that we see in Cushing syndrome patients, we don't often see in physiological or pseudo-Cushing patients. More importantly, when trying to differentiate these patients with pseudo-Cushing or physiological Cushing from true Cushing syndrome, it's very important to exclude based on other potential causes of physiological Cushing's that may include PCOS, obesity, psychological or physical distress, and those include major depression and long-standing pain syndromes, as well as poorly controlled diabetes and obstructive sleep apnea. Those are the most common sources or causes for abnormal cortisol levels that are just physiological. So once we have 2 out of these 3 screening tests abnormal, and this is the 24-hour urinary free cortisol, midnight salivary cortisol levels, or the 1 milligram, often referred to as a low-dose dexamethasone suppression test, then we can definitely say this patient has a Cushing syndrome. Then the next step, which is the second step and easy step, is to determine whether this is a ACTH dependent versus ACTH independent hypercortisolemia. On the ACTH dependent, that means there is a tumor in some part of the body producing ACTH. And when that happens, the ACTH levels are going to be elevated. When it's ACTH independent hypercortisolemia, often you have a tumor or patients have a tumor in the adrenal glands that are independently producing cortisol. And then what's going to happen to the ACTH levels is they're going to come down because of the negative feedback from the adrenals to the pituitary gland. So this is kind of the straightforward part to differentiate patients with Cushing's syndrome, whether they are ACTH dependent versus ACTH independent. And it's all based on the ACTH levels. Now, the third aspect is when we already establish that a patient has an ACTH-dependent hypercortisolemia, meaning increased cortisol from a source or a tumor producing ACTH. This is where the role of imaging and inferior petrosal sinus come, because we need to try to differentiate whether that source of ACTH is coming from the pituitary gland or from an ectopic source in other parts of the body. It's also a challenge because often if these patients with hypercortisolemia are being investigated in a center that's not used to working up these patients, right after a random elevated cortisol, there's always a pituitary gland imaging without going through all that process. And because incidentaloma, so tumors on the pituitary gland with absolutely no symptoms or function, are highly frequent and prevalent about 10 to 20% of the population, Then you're dealing with incomplete laboratory workup, and now with the imaging that shows a small tumor in the gland. And then we're trying to connect the dots and trying to make sense on what is actually happening. So we are often seeing patients in this scenario with some questionable imaging in the pituitary gland. And what I tell my patients is that the finding on the MRI depends a lot on the context. And the context that I'm talking about is clinical symptoms, clinical signs, and laboratory evidence of abnormalities that would suggest an ACTH-dependent hypercortisolemia. Now, there are what we call the high-dose dexamethasone suppression test and the stimulation test that could be done with either CRH or desmopressin. These are non-invasive tests, but they're often done prior to the IPSS or imaging in trying to diagnose or trying to differentiate whether the source of the ACTH is coming from the pituitary gland or some other part of the body. The challenge is that the CRH stimulation test, up to 15% of patients with Cushing's disease and those with ectopic secretion of ACTH may be misdiagnosed by this test. Similar to the high-dose DAC suppression test, up to 50% of patients with Cushing's disease may fail to respond. So what ends up happening is that these are often done because they are non-invasive, but they may still mislead clinicians in their workup of a patient with pituitary ACTH secreting tumor. So ultimately, sometimes these tests may be combined in trying to improve the accuracy of and the likelihood of diagnosing, but the gold standard in differentiating a pituitary source versus an ectopic source is the IPSS. But imaging is often done first in this workup process, and we'll talk about it why. Pituitary imaging, and we're referring to an MRI with and without contrast that's focused on the pituitary gland. That has dramatically improved the diagnosis of small lesions in the pituitary gland. More importantly, dynamic contrast enhanced protocols has also increased the sensitivity and improved the diagnosis of small lesions from 60% to 80%. A lot of patients do not know about this dynamic sequence, but they're not done everywhere. But ultimately, what happens is the pituitary gland enhances very avidly with the contrast. So when we're looking into a tumor in the pituitary gland, we are looking for darker areas, for hypoenhancing areas in relationship to the gland. Now, when you have a very small tumor and the imaging acquisition is done in a delayed fashion, what happens is the enhancement of the gland hides that small tumor. And the solution to trying to overcome that problem is that it's the dynamic sequence. So basically thin cuts or slices are performed in the pituitary gland area, and they're acquired dynamically after the contrast injection. So in this way, we can see several phases of the contrast as it spreads through the gland and it's being washed out. So you can see the sequence here of events or a sequence of images where you have zero contrast in the pituitary gland. You have the carotids here. Then you start to see some faint enhancement in the gland. And here you can start to see this area, a small area of hypoenhancement, which is highly suspicious for a microadenoma or a small pituitary tumor. And you can see here as well. Once the contrast is being homogeneously or evenly spread throughout the gland, that in a more delayed fashion, then it becomes a little more challenging to see it. the same time, we increased our sensitivity in finding these small tumors, but we also increased the incidence of false positive readings on MRI scan. So we can, and that's what I emphasize to patients, that we cannot rely entirely on imaging, especially for small tumors, smaller than 6 millimeters. Because a lot of times what we're seeing is not a true tumor, but some uneven or heterogeneous enhancement of the pituitary gland. And the value that we're going to give to that specific imaging will depend on the context. The context, again, is the clinical symptoms and laboratorial evidence that will make us more concerned or less concerned of the imaging findings on the MRI scan. There are new and better imaging sequencing and focused on the pituitary gland, as well as the quality of the scanner itself. There is a sequence that's called spoil gradient echo, or SGE. That is the sequence in the middle. It has been studied in a research setting and also a limited clinical setting, and is characterized by superior soft tissue contrast and improved resolution that can be performed in sections of 1 millimeter slices. There are other names for these specific sequence depending on the manufacturer technique, but the technique itself it's identical. And the SGE sequence shows higher sensitivity than has shown to be have a higher sensitivity than the dynamic sequence that I talked about previously. But again, it is also leads us to higher rates of false positive findings on the MRI scanner. So in a clinical setting, what we really rely on is the dynamic sequence, clinical and laboratory context, and as well as other usual T2 signals that are done in every pituitary protocol to kind of determine whether the imaging findings are more or less significant. What we're hoping for in the future is having, besides the imaging quality, but also having radio tracer that can hopefully tell us whether that imaging on the MRI is real or not, or functioning or not. There has been a lot of work done from a research standpoint using methionine PET scan merged with MRI scan, and that can, with the hopes that would potentially tell us whether a hypoenhancing on the MRI has any function or active function. That's being done from a research standpoint, but not from a clinical standpoint. It's not widely performed. Other types of PETs or tracer have been studied in the pituitary gland, but ultimately there's no useful clinical role for the FDG PET, which is the glucose tracer, and other somatostatin receptors PET scan also hasn't proven its role in diagnosing these challenging lesions. Nevertheless, I would like to bring the attention to this study where they have developed a new tracer that's targeted to CRH1 receptors expressed in or highly expressed in cortical trough adenomas, so pituitary tumors that produce ACTH. This is a non-commercially available tracer, but ultimately the authors demonstrated a high accuracy in detection of pituitary adenomas in 24 patients with Cushing's disease that were afterwards confirmed by intraoperative and histological pathology findings. So ultimately, the authors were able to identify equivocal or small lesions, and those lesions were highlighted by the CRH1 tracer, and that facilitated the diagnosis of that lesion as being a functioning lesion and the cause of the Cushing's disease. However, it's important to know that only 10 patients had microadenomas smaller than 6 millimeters. And of these, only 4 had no lesion visible on the MRI. So ultimately, that's where the inferior petrosal sinus sampling comes in. So this is an invasive test, but it's most used, or it is most useful in patients that have laboratorial evidence of Cushing syndrome or ACTH-dependent hypercortisolemia, but either a very small, meaning less than 6 millimeter lesion on MRI scan, or what we call an MRI negative Cushing. So we have clinical and laboratorial evidence, but no signs of tumor on the MRI scan. Just to give a little bit of history, the IPSS, or inferior petrosal sinus sampling, was first described in 1977 at the Walter Reed Army Medical Center, and that was done with a selective bilateral but not simultaneous catheterization via transjugular approach, so kind of accessing directly through the neck all the way up to the petrosal sinus. And this ended up being evolved to a multi-step process where it was performed a bilateral simultaneous catheterization, and afterwards by utilizing the CRH stimulation, which is the hormone that stimulates the gland and tumors to secrete ACTH. And the whole idea of this test is putting small catheters in the inferior petrosal sinus, which is one of the main outflows of venous blood drainage from the pituitary gland, and comparing the samples just around of these blood samples just around the pituitary gland compared to the levels of blood samples coming out of the periphery. Ultimately, if we have an increase in ACTH that is greater than a 2-to-1 ratio before performing the stimulation with CRH or desmopressin, or after the stimulation, if that ratio is greater than 3, then it's almost certain that the culprit or the cause of the Cushing's syndrome is coming from a source in the pituitary gland. There was strong work performed by Dr. Edward Oldfield at NIH with IPSS and its improvement with stimulation, and they published in the early 90s the first large series supporting the use of the IPSS in diagnosing these patients with Cushing's and no obvious evidence of tumor on the imaging. I would like to note that the technology of MRI scan was not well developed at the time, so he had a much greater importance. Dr. James Fidling from Wisconsin also published in the early 90s smaller series, and he was responsible in the early 2000s to use the prolactin as a surrogate for pituitary venous efflux, meaning that trying to reduce the error or the misdiagnosis of the IPSS, and I'll go in a little more detail on why we measure prolactin during the test as well. To the technique that we currently use. So just to give you an overview and how this is performed, there are different nuances and ways on how this procedure can be done. We have the preference of obtaining bilateral femoral vein access. We rarely use arterial access for the procedure, only in extremely challenging cases or we usually get a 7 French sheath on the right side. So we need a larger introducer, because that will allow us to do the peripheral blood samples from the periphery, from the groin area. And we usually use a 5 French sheath on the left side. Then we use a 5 French Berenstein catheter that is our almost like as a guide. It's a diagnostic catheter that we use as a guide catheter to navigate all the way up to the internal jugular vein. And we do that on both sides, and then we telescope a microcatheter, a 2.8 French microcatheter, through that 5 French Berenstein, and that's that's the catheter that's going to be inside the petrosal sinus for the blood sample. Because these microcatheters are very small and it is difficult to pull out the blood samples from it, we use this strategy of putting a hemostat or clamps to keep the continuous flow of the blood, and facilitates the blood draws in a timely manner, as well as prevent clot to form into the microcatheter that could prevent our blood samples to be done in the accurate timestamps. From a technical standpoint, the procedure is relatively simple, but there's a lot of team and organization that has to take place in the IR suite. These procedures are done under local or anesthesia and sedation, so patients are pretty much awake for the procedure. And we have it requires a lot of coordination of the entire team working in the procedure room. And we try to do things to facilitate the organization, because if you have a successful catheter in place and you mislabel or have wrong samples going to wrong spots, the test on itself is useless. That's why the organization is as important as the technical aspects of putting the catheter in the correct position. So because of that, what we do is we send our samples from the inferior petrosal sinus in 3 cc syringes that facilitates differentiating from the peripheral samples that we send out in 10 cc syringes. There's a lot of closed loop communication in the procedure, where we're handing out each blood sample specimen and getting confirmation from the nurse team in the room that for what that a specific specimen stands for. And again, we use this strategy of using a hemostat to maintain the blood draw coming out of the microcatheters while we do performing the other samples. We have these table to make sure we acquiring all the blood samples in a timely manner. And the nurses, once we complete each timestamp, we have 6 samples. So every time we complete the entire set, we checked off and confirmed we got all the samples that are needed for that timestamp. So what happens once the catheters are in place, we do blood samples -10 as baseline, -5. Then we inject the stimulation. We perform the drug stimulation that can be done with either desmopressin or CRH. The CRH has been out of market and not available in the United States for some time now, probably about 2 years. So we have been using desmopressin at a dose of 10 micrograms IV push, and that's performed at a time 0. Then once that stimulation is performed, we do measurements of at +2, +5, +10, and +15 minutes. And at each timestamp, we are collecting 3 samples that is for ACTH. So periphery, left inferior petrosal sinus, and right petrosal sinus. We do the same thing for prolactin. Periphery, left inferior petrosal sinus, and left inferior petrosal sinus for the prolactin. The way we found to organize the samples, the number of samples during the procedure room, is having one nurse responsible for all the ACTH samples and the other nurse responsible for all the prolactin samples. There also we also need to check that their samples are being placed in the appropriate tubes, the lavender cap for ACTH and tiger cap for prolactin. And once the samples are inside the tubes, they need to be stored in the procedure room in eyes for accurate management, for accurate measurement. And we basically put them in ice and we separate them as this is how it looks like at the end of the sampling. We have the -10, -5, +2, 5, 10, and 15 after the stimulation. And you see here our table that has been checked off that all the samples were collected. And from an anatomical standpoint, all we're doing is we getting the guide catheter up to this level of the jugular vein, and then because of the favorable anatomical direction, we place the microcatheter in the inferior petrosal sinus, which is located right here, and is one of the main venous outflow of the pituitary gland, along with the basilar plexus and the superior petrosal sinus here. Now, we can't really easily access the basilar plexus or superior petrosal sinus, so that's why we do it in the inferior petrosal sinus. From a technical standpoint, the inferior petrosal sinus runs in the petroclival synchondrosis, so it's the junction between the petrous bone and the clivus region of the occipital bone. And that can be seen here on the true AP X-ray, where you can see this kind of curvature of the petroclival synchondrosis on both sides. And that's what we use when we're trying to get the microcatheter in without exactly knowing where the IPS is. Once we get one of the catheters or one of the sides in, we can use the contrast injection to show us the exact position of the contralateral, so the IPS on the other side. This is a short video that if the video is running, but it's a short video that shows you what happens with the technique when we perform the inferior petrosal sinus. So this is basically we're running the contrast from one way to the other. Here I have a roadmap that shows me the position, and we advance a micro wire, and then this is the guide catheter and the micro catheter kind of being placed on it. So here the injection coming from the right side, and you see in the true AP here that the catheter is in position and the microcatheter is higher up in the petrosal sinus. So as I mentioned before, the IPSS is the gold standard. It has a sensitivity and specificity of 96 and 100% in differentiated central versus an ectopic source of ACTH. And this is what we use as a guidance. So if you have IPS to periphery ACTH ratios more than 2 at baseline or more than 3 after stimulation with CRH and DDAVP, that's almost certain diagnosis of central source of pituitary source of ACTH. The lateralization, meaning because we have catheters on both sides, having one side showing higher elevations of ACTH in the past, it was used to guide the gland exploration or even a resection of one side of the gland if that gradient was greater than 1.4. Now we know that is there's a lot of things that impact on the lateralization of the of the uh, of the IPS when performing IPSS, and we cannot trust uh, uh, the lateralization of these studies as well as we trust the that these patients have a pituitary source of the ACTH. So what we use and how do we use this information is that we have to account for anatomical variance and dominance of the venous outflow around the sella and the pituitary gland. But how that guides us is that in the past, if an IPSS showed that the tumor was most likely on the right side, we used to resect the entire right hand side of the pituitary gland, trusting that the IPSS was providing the most likely or accurate position of the tumor. The problem with that strategy is that it is often, the IPSS is often inaccurate in lateralizing the position of the tumor. And for those patients that have persistent disease after an hemihypophysectomy, then you're dealing with a very high risk of patients develop hypopituitarism, because all is left is to take the other side of the gland, and that's likely going to make the patient's uh, pituitary hypofunction. So what that change a little bit is the way we approach this and approach the gland exploration. So often, instead of blindly trusting on the lateralization, we take it with a grain of salt and put it in the context of dominance of venous outflow, as well as any hints or suspicious areas on the MRI scan to make a decision on how we explore the pituitary gland afterwards. The use of the prolactin normalized ratios has improved the accuracy of the IPSS, and basically increasing our sensitivity and specificity, because the prolactin is used as a surrogate that we have our catheter in a good position, and that the blood that's being drawn from that IPS is accurate for the venous drainage of the pituitary gland. So then that would mean that the ACTH levels could be trustworthy, as opposed to having technical difficulties or an abnormal venous drainage of the gland, where the ACTH levels may be misleading, in the sense that we could have a false negative result. Common issues with the IPSS are anatomical variations, so having the inferior petrosal sinus anastomosing to vertebrovenous plexus, so us not having the catheter in a good position, but the blood sample not being an accurate blood sample that is true representative of the venous outflow of the pituitary gland. Sometimes there is no connection between the inferior petrosal sinus and the jugular vein, or there is a hypoplastic inferior petrosal sinus, meaning they're very small or asymmetric, that can also create some challenges in the sampling of some patients. There's also the possibility of using the sample from the cavernous sinus or jugular vein, but the current literature suggests that the sensitivity of jugular vein sample are much lower, ranging from the high 60s to low 80% compared to the high 90s for the inferior petrosal sinus sampling. And the prevalence of IPS abnormalities exceeds that of false negative results, meaning that the anatomical variation is often blamed for an inaccurate petrosal sinus sampling, but often the true issue is some technical problem that is occurred during the IPSS procedure. It is important to highlight the true indications of these procedures, and a lot of times there are misconceptions on the indications. So the true indications for IPSS are patients without a pituitary lesion MRI or lesions smaller than 6 millimeter that have biochemical Cushing's disease or Cushing syndrome. And then we're truly trying to differentiate whether that's a central versus peripheral. We have a diagnosis of ACTH-dependent hypercortisolemia, and the lesion that is 1 centimeter, we can safely say that that's the culprit, or that's the source of the problem in up to 70% of those cases. So we are really restricting our cases for either very small tumor, meaning they're less than 6 millimeter that we see some suspicious areas on MRI, or we don't see, or cases that we have laboratorial and clinical evidence, but no lesion on MRI. There's also indications in patients with biochemical Cushing's disease who have undergone subtotal or total hypophysectomy without clinical improvement or any effect on ACTH secretion. And that includes patients not having a pathological diagnosis. If a patient has had prior surgery and does have a pathology confirming a cortical trough adenoma, the chances that there is a tumor in the cello or residual or recurrence are very high, so the indications for a PSS are questionable in those scenarios. Because it's very rare and unlikely that a patient with a Cushing's disease or a pathological diagnosed Cushing disease in the past will develop an ectopic source or somewhere else. The other indications are patients with the above indications in previous IPSS that was technically unsuccessful, whether it was unsuccessful or that are questions of improper catheterization, questions about the sampling, handling of the samples, anything that we could be questionable in prior IPSS. There is no reason not to repeat the test, and a lot of times that's what needs to be done to accurately diagnose these patients. When is IPSS not indicated? So it's not the test used to differentiate Cushing syndrome from pseudo-Cushing. Remember, if you go back to that priority hierarchy, before we get to a point that we need to do IPSS, we really need to differentiate clinically and with non-invasive testing the ACTH or hypercortisolemia from pseudo-Cushing states. So IPSS is not the test to do so. IPSS is not indicated when you have an ACTH-dependent hypercortisolemia proven by clinical and laboratory evidence and a tumor greater than 6 millimeter. Then the chances are that is the culprit. It's also not indicated to determine lateralization of a pituitary tumor secreting ACTH when you have a negative MRI that cannot be trusted. It's also not indicated in recurrent or residual Cushing's disease if that diagnosis was confirmed by ACTH staining cortical trough tumor. This is a very nice workflow that was published in 2021 in a review of the role of the IPSS, and it's basically used to confirm endogenous ACTH-dependent Cushing syndrome when there is no evidence of tumor in the MRI or tumor less than 6 millimeters. We look for those IPS periphery ACTH ratios. If it is present, it's confirmed this is coming from the pituitary gland. If it is absent, we need to determine whether this was a technical or a sampling error, and that's why the prolactin ratio is used during the sample to tell us that that blood sample for the ACTH is truly coming from the pituitary gland. If the IPS peripheral prolactin ratio is greater than 1.3, then it means that it is accurate and we're dealing with the ectopic source of ACTH. If it is not, then we have to proceed with calculate the prolactin adjusted IPS to peripheral ratio, and that can give us three different scenarios. Very likely to be ectopic, indeterminate, or likely to be of a central or pituitary source. And that's the literature, and that's what we have in the literature or evidence in the literature supporting our management strategy. So high sensitivity and specificity in diagnosing Cushing's disease. Intersinus ratios is not used for tumor lateralization because they're fairly inaccurate in majority of the cases. There is some studies and conflicting data in the literature using the prolactin adjusted IPS versus periphery ratio to try to improve the lateralization, but we ultimately have to use the combination of the venous anatomy, imaging findings, and absolute numbers on the IPSS. So I just want to finalize with some case examples on that we used the IPSS. So this was a case of a 69-year-old progressive weight gain, facial hair growth, fast fat redistribution, truncal obesity, supraclavicular fat pads, developing hair loss, anxiety, depression, dizziness, and palpitations. I want to highlight that a lot of these are also seen in pseudo Cushing and or physiological Cushing cases. And she did have a past medical history of hypertension, hyperlipidemia, and rheumatoid arthritis. She had many random morning cortisol that were either slightly elevated or within normal levels with mildly elevation of ACTH. Her workup it took, as most Cushing's disease patients, it takes a while until we can confirm the diagnosis, and eventually we were able to have 2 of the 3 screening tests abnormal, which in her case was the midnight salivary cortisol and elevated 24-hour UFC. That ultimately confirmed the hypercortisolemia, and the elevated ACTH confirmed that she had the Cushing syndrome. So she had an ACTH-dependent hypercortisolemia. MRI of the pituitary gland was equivocal. It looked like a normal gland, maybe some area of hypoenhancement, but we could not find a definitive evidence of tumor in the pituitary gland. Then we proceeded with IPSS, and that's what the result will look like. So we take all these blood samples and we chart it and to see how they'll look like. We always, one thing I forgot to mention is we always check the morning cortisol the day of the procedure, and if that's below 10, we do not proceed or we do not do the procedure because that may lead to a false negative testing. So we often wait for that morning cortisol before heading back to the procedure room. In this case, we look at the numbers here as we get a IPS to periphery ratio. This is pre-stimulation. We got a number that is above, or actually 2 numbers that are above 2, and post-stimulation, all of the timestamp on the right side showed that there was a great a ratio of IPS to peripheral greater than 3. So this makes us very confident that this patient has Cushing's disease, and that lead us to what we do, which is the gland exploration. As I mentioned in the past, we used to do a lot of hemihypophysectomies, meaning taking the entire side of the gland out. We know that patients that have a third of the normal gland are usually able to maintain their baseline needs of pituitary function, pituitary hormone production and function. But we have moved away from taking entire sections of the gland to what we call a gland exploration. Because corticotroph adenomas are the majority located on the sides or center of the gland, what we started doing is we're slicing after exposing the entire gland, we started slicing the gland and keeping the top connected, and we slice in every 2 to 3 millimeters. So we put 3, 4, 5 cuts on the gland while keeping the top detached, and then basically looking for any sign of or suspicious tumor or suspicious tissue that would be compatible with ACTH pituitary adenoma. And a lot of times we'll find kind of the softer tissue as compared to the normal gland tissue, and that is very satisfying when that happens, when you have a completely negative imaging and we do find something in the pituitary gland during the surgery. This is what the gland looked like before. This is what it looked like right after surgery, after we explored it. But most importantly, besides getting the pathological diagnosis, we train the cortisol nadir after the surgery. And this is specifically done for ACTH, for Cushing's disease patients. So I do talk to patients that they will not feel well after the surgery because they are used to high levels of cortisol, and the cortisol is the stress hormone, gives patients energy as well. And when we have a successful surgery and the cortisol drops, the patients feel very, very tired. And in more extreme situations, they may have changes in heart rate, decrease in blood pressure. That is a signs that our patients are in adrenal insufficiency, and then we need to restart or resume their cortisol replacement. But we do want to see, and we target our cortisol nadir after surgery. We want to see a drop it below 2. That gives us confidence that the patient will likely be cured from the Cushing's. In larger tumors, it's also a good surrogate, or at least a good sign for long-term remission. And if the patients do not drop below 2, it makes us more aware to the immediate post-op MRI. And if there is a residual tumor, we're more prone to go back and resect it while there's a fresh surgical cavity, as opposed to waiting for 3 months on when everything is scarred down. So this specific patient had a cortisol nadir of 1.7. When we reach that level below 2, then we start patients on hydrocortisone replacement. Patient symptomatically was feeling better in 2 to 3 weeks, and that hydrocortisone was eventually weaned off. In 6 months, she lost approximately 60 pounds, and she's very happy with this. This is another similar case, young patient with progressive weight gain, hyperlipidemia and acne for 2 years, and had a random cortisol that's high, normal with the increased ACTH. She did have a very high clinical suspicion and abnormal low-dose dextrodepression test and midnight salivary cortisol in a normal 24-hour UFC. On imaging investigation, there was this 5 millimeter that was a highly suspicious lesion, but because of the size, and she was a young patient, we still wanted to do the petrosal sinus sampling to confirm that the gland exploration was the right thing to do. Even in cases like this, where you do have something suspicious on the left side, we would still explore the entire gland to make sure we're not missing on anything, because a lot of times this can be deceiving. Per IPSS, interestingly, we saw that suspicious lesion on the left side of the gland, but we did have lateralization on both sides that can also be confusing sometimes. But we had definitive evidence based on the periphery IPS periphery ratio that this was a central source. We took her to surgery. We ended up finding that lesion that was suspicious on an MRI on the left side. It was compatible with tumor. Similar thing, we waited for the cortisol nadir, and she dropped to 1.1 in the post-op day 2, and it did very well after surgery. Lost about 40 pounds in 6 months, and has improved symptoms. That's what it looks like. That's what it looked like before. This is kind of the delayed post-op MRI. You can still see that she has an intact pituitary gland, because we make all the effort necessary to preserve gland tissue and avoid hypopituitarism, and no signs of residual tumor there. Now, obviously, not all cases are straightforward, like in happy cases like we presented. There are a lot of cases that are very challenging. This is a case of a 50-year-old progressive weight gain, facial hair growth, supraclavicular fat pads, purple stretch marks, very classic findings that we see in Cushing's disease patients. She also had a medical history of depression and chronic pain, chronic low back pain. Also, common things that we see in pseudo-Cushing states. And this patient was very, very challenging, because it was probably around 2 or 3 years she had some abnormal tests and some normal tests, and we were obviously considering the possibility of a cyclic Cushing's disease. And we kept testing and retesting her, and we were never able to get those 2 out of those 3 screening tests at the same time abnormal. We had it over time, one versus the other, but not in the same time period. In addition, she ended up getting a pituitary MRI, and radiologist was reading as a possible hypoenhancement on the right side of the gland, just to make things more challenging. So after testing and retesting her, we were very hesitant in taking her for surgery exploration based on her non-invasive test. And then after one abnormal midnight cerebral cortisol and a low dose dextro suppression test, we decided to do desmopressin stimulation test, non-invasive, and she did respond with an increase of 50% of her baseline, which is indicative of central source. So we decided, based on this, to take her to petrosal sinus sampling. Obviously, her case was not straightforward. We were able to catheterize the right IPS, could not get through this narrowing or stenosis on the left internal jugular vein. And she had prior history of central venous catheter with thrombosis. We were able to identify this by putting the catheter into the external jugular, and we could see the anastomosis, and we see that was the point where we could not get through with our guide wires and catheters. So at some point, after trying for about an hour to get the catheter up, and even attempting to go to the contralateral side from the right side, we decided to proceed with the unilateral sampling. And that's the result that we got. We didn't get the sampling on the left, and that's the sampling we got from the right side. And when I charted those numbers, if you see here, we do get a ratio greater than 2 from IPS to periphery before stimulation and greater than 3 after stimulation. But what concerned me was the patient's absolute numbers, right? The patient's ACTH numbers were in the single or even the highest like double digits. And usually this is not something that's written in books and publication, but with the experience, we often see that patients that truly have um, a central source or a pituitary tumor as the cause of the Cushing's, we see these numbers in the triple digits after stimulation. To make things more complicated, we didn't have the contralateral side, the left side. And it wasn't because we weren't able to put the microcatheter into the IPS. It was just a blockage at the level of the neck, which wouldn't be resolved, or it wouldn't change if we tried to do this procedure again. So after a lot of back and forth, we discussed with the patient that these findings weren't too exciting, although we did find the ratio, the absolute the ratio that would indicate a central source. The absolute numbers weren't too exciting, and then patient was tired and decided to give it a try and see what we will find in the gland exploration, particularly in the setting of having this imaging on the pituitary gland. And her exploration was negative. So we basically did the same thing that we did. We did the same thing as we do for our MRI negative cases. We exposed the entirety of the gland. We put slices and keep the top of the gland connected. And we didn't find anything that looked abnormal during the procedure. But we still tracked her cortisol, and as you can see here, the cortisol nadir kind of plateau around 9, 8 post-op, and that is an indication that there was probably never a tumor there. She lost about 6 pounds in 6 months, but there was no real significant clinical improvement as we would expect. The fortunate thing that we didn't damage her pituitary function by doing the gland exploration. So by keeping the top attached, this is what her pituitary gland looks like in a delayed fashion. And she was able to maintain her at least a normal pituitary gland function. Other challenging case, this is a patient that 58 that was operated in outside institution. She was identified with she was undergoing through workup after a treatment of breast cancer, and had an elevated ACTH and cortisol levels, and that led to an IPSS and surgical exploration in outside institution. Unfortunately, what was done is they relied on the lateralization of the IPSS and took the left side of her gland out. That's the initial imaging. She had maybe some suspicious area right in the midline. You see like a darker dot there, but the surgeon opted to take the left gland out. Obviously, she did not have improvement of symptoms or labs, and she transferred care, and she was followed by our endocrinology team, basically with elevated ACTH and cortisol levels. But imaging, there was no signs of tumor on the pituitary gland. And you can see she had remaining of the right side of the gland, but no tissue on the left side that was resected. No obvious tumor, still experiencing symptoms. Her symptoms were mild, but the laboratory investigation was unequivocal that it was something going on. We even went to extent of performing a data tape PET that is targeted to somatostatin receptors. These are expressed in cortical trough adenomas. was completely normal, just a normal uptake. Didn't find anything, anywhere else in the body. So then we decided to go to the petrosal sinus sampling. And it is unfortunate that this specific patient, I was very confident we would find something. And the numbers here, she had some response after stimulation, but numbers never got to the triple digits as I would expect. But most importantly, the ratios were all below 2 and 3 pre and post stimulation. Now, this could be a limitation on our sampling error. So we did do the prolactin weighted calculations, and basically put us on this indeterminate segment, which her calculated prolactin adjusted IPSS to periphery, it was 1. So it put us in this indeterminate. And during the procedure, I felt very confident. We have documentation that the catheter was in a good spot. The catheter wasn't displaced during the sampling. And the only thing that I can think of what is that of her venous anastomosis, we're not getting a good venous blood that was truly coming from the gland because of collateral flow. Now that wouldn't really change, and because I felt very confident about the technique. This patient just started on medical therapy because I feel the risk-benefit profile on exploring the rest of the gland, of her gland, it is higher because there will be a higher likelihood that she could become upon hypopit from exploring already a gland that was already taken by half. And we're probably going to follow her and see if anything will declare itself, and maybe potentially repeat this test in the future. And this is just a last case, but is a recent one. 67-year-old with history of adrenal nodules, being followed since 2012, and had some mild elevations of cortisol, ACTH. There was concern that the adrenal nodules could be the potential source for this mild elevation, but the patient's symptoms are always very mild. She doesn't look like a Cushing's patient from a clinical standpoint. She works out a lot. It's not obese. But one thing that the endocrinologist found is that over the years, her diabetes type 2 became more and more difficult to control. And that was a concern and a red flag. And then over the years, we noticed that her laboratory findings started to become more consistently abnormal. No, the cortisol levels and ACTH were never through the roofs, always normal or if elevated, mild elevation. But we finally identified, after repeating tests for years, we finally identified 2 abnormal midnight salivary cortisols with abnormal low dose DEX suppression test. For 24-hour UFC, always normal, and no other findings in the chest and abdomen besides the adrenal nodules that have been stable in size for years. Then pituitary image showed this, like a 4-millimeter lesion. Could be something, could be just an incidentalloma. So we convinced her, because she was always, she's a patient that was always in denial about the true value of her symptoms and challenges in the controlling her diabetes. But she finally gave in, and we did this IPSS. And this is like a classic positive study. You can see that there is a preference towards the right side, but the numbers, the absolute numbers of ACTH on the thousands, this is very, very likely that we're dealing with the ACTH secreting tumor. Again, lateralizing to the right side, but our suspicion area is on the left. So for her, obviously, we're going to focus on this area, but we're going to explore the entirety of the gland, and we're hoping to do her surgery soon. So in conclusion, The IPSS role is in differentiating Cushing's disease from an ectopic source of Cushing syndrome in MRI negative or lesions less than 6 millimeter on the pituitary gland. The prolactin levels are very useful during IPSS, and it can improve the rate of false negative studies. Potentially lateralization, but that cannot be trusted with the data we have in the literature nowadays. But ultimately, the role of the IPSS is not the same as 20, 30 years ago, and it's likely going to diminish as we evolve on molecular imaging that will specifically target receptors that are expressed in these tumors, and we would be hopefully able to use tracers that can tell us whether the imaging finding that we see on MRI, it's something functioning or not, or if it's a tumor that is causing the disease. I'd like to acknowledge and thank the entire skull base and pituitary team here at Moffitt. We have a big team that work together in multidisciplinary fashion, and I'll be happy to take any questions if there are any.
Thank you, Doctor, for a thorough and valuable presentation. We are actually out of time today for questions, but we do invite anybody who has any questions to email us directly through our website, and we can get them to you and get the answers back to them. And thank you again. This will conclude today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family members or friends, it will be available on our website at www.pituitary.org after it is edited. There will be a brief survey after the webinar. Please feel free to help us out, provide you with any information you need. Thank you again for joining us, and thank you, Dr. Beer-Furlan, for your presentation. It was amazing.
Thank you.
Have a great day.